Hi, I'm coming to ask you for a favor. No. Tomorrow, and we do it when you come back. Okay. He was like, no, that's not right. I said, we wanted to
Test.
just in case, but we figured we need to come back.
Test.
Yo, I think we met. Yeah, exactly.
I don't have any other.
Come back if you want on the
All right, everybody, we're going to get started, so please grab a seat.
Thanks.
Thor, am I ready? Okay. Good morning, everyone, and thank you for coming back after your break. We hope you've enjoyed everything so far, and I know many of you know our next speakers, and if you haven't met them yet, hope 2 days you'll have a chance to meet with them and speak with them a bit more. But it's my pleasure to introduce you to our next speakers who are here to talk with us about the neurodevelopmental profile of Wiedemann-Steiner syndrome, the preliminary findings and future directions. First, I'll introduce Dr. Rowena Ng. She is a clinical neuropsychologist at the Kennedy Krieger Institute and an assistant professor of psychiatry and behavioral sciences at Johns Hopkins Medicine. Her clinical interests include providing assessment services for children and adolescents with rare genetic congenital conditions, including Mendelian disorders of epigenetic machinery, such as Wiedemann-Steiner syndrome. Her research interests focus on integrating multidisciplinary methods in characterizing social and cognitive phenotypes associated with rare neurogenetic diseases in efforts to identify potential outcome markers for targeted clinical trials and optimize early clinical behavioral management. Next, we have Dr. Jacqueline Harris. And she is a child neurologist and neurodevelopmental pediatrician and an assistant professor in the Department of Pediatrics, Neurology, and Genetics at Johns Hopkins University of Medicine and Kennedy Krieger Institute. She currently cares for hundreds of patients with epigenetic disorders with neurologic and cognitive manifestations in clinics at both Johns Hopkins Medical Institution and Kennedy Krieger Institute, including patients with Wiedemann-Steiner syndrome. And if you've had a chance to visit Johns Hopkins, you've probably had a chance to meet Dr. Harris and Dr. Ng. Her research focuses on epigenetic causes of neurodevelopmental disorders, particularly intellectual disability, and how specific epigenetic changes lead to specific neuroanatomic, neurophysiologic, and cognitive phenotypes. She's also interested in developing specific cognitive profiles in genetic syndromes as potential outcome measures for clinical trials and running these trials. And you can read more about her and Dr. Ng on our online program, so we encourage you to go to that to check it out. And so without further ado, I'll hand it over to our first speaker. Thank you so much.
Thank you so much, Crystal. All
Yes, as Crystal said, we're going to talk about the neurodevelopmental profile of Wiedemann-Steiner syndrome and some of the findings based on our studies so far and where we plan to go next. Next slide. What we're going to do in the talk today between the two of us is review the neurodevelopmental profile associated with Wiedemann-Steiner syndrome. That's what I'm going to do. I'm just sort of the lead-in to the star speaker today, who is Dr. Eng. She's then going to talk about the clinical and research utility of neuropsychological evaluations and preliminary study findings and future directions. Next. Yep. Next. So what are neurodevelopmental disabilities? So neurodevelopmental disabilities are things that we call phenotypes or symptoms or presentations of an underlying condition, and they're descriptions of patterns of thinking and learning and behavior. And some of these that you have probably heard of before include intellectual disability, ADHD, autism, specific learning disabilities, cerebral palsy, language disorders, anxiety, and many, many more. Next slide. And for these neurodevelopmental disabilities, overlap and multiple of these are the rule, not the exception, especially in these genetic syndromes like Wiedemann-Steiner. So when you have something that affects the development of the brain, it doesn't just, occur in isolation and only affect the ability to learn or only affect the way that we process information and get anxious. It affects multiple of those things. And so all of our kiddos have usually at least multiple of these, and many of them have even more, but they're all a little bit different in how they present. But it's not caused by different things. It's all caused by Wiedemann-Steiner, but how it presents as far as neurodevelopment can be a little bit different. Next slide. And one of the things we want to understand is, like we said, all of our kids are different from each other. All of our kids have different struggles, different things that are more difficult or less difficult. However, there are certain things that are strengths and weaknesses that are associated with specific genetic syndromes. So although, Kid A is different from Kid B is different from Kid C, what we really want to understand is what are the things that are specific to Wiedemann-Steiner syndrome. So what are the things that is caused by the Wiedemann-Steiner versus all of the other things that can influence brain development and behaviors, and what is what we call the profile. And so in several syndromes, we already have, based on published literature, a good idea, or at least a starting idea of what the profile might look like. And so we'd like to develop this for Wiedemann-Steiner syndrome as well. Next. And so the first thing we do when we ask this question is to go back and look at what has been published. So prior to this calendar year, the descriptions as far as the neurocognitive and neurobehavioral phenotype of people with Wiedemann-Steiner syndrome was limited to non-existent in the published literature. It was published that they had mild to severe intellectual disability, which is really broad and really general and not very helpful. Significant anxiety and executive functioning issues, although that was not as published as we had experienced in our clinical practice. Social cognitive issues, sometimes accompanied by autistic features, again, more so an observation of ours than had been published in the literature. And that behavioral issues often lead to adaptive functioning that is lower than cognition, meaning the children were very intelligent, were able to do a lot of the things and perform well, but there are certain behavioral phenotypes that got in the way. That they had poor sleep even after sleep apnea correction, early hypotonia that improves with age, although never goes away completely. Seizures more common than in the general population, but still not very common overall. And about half of patients have a minor finding on brain MRI, although it's very rare to have a major finding. Next. So neurologically, the first thing that often presents in a baby with Wiedemann-Steiner, again, from a neurologic perspective, is hypotonia or low muscle tone. According to a large paper that we contributed to last year, it's present in about 73% of patients with Wiedemann-Steiner syndrome, although that paper was largely based on sort of clinician reports of things. And so we think that's probably an underrepresentation. So we think probably almost all the kids with Wiedemann-Steiner have at least some degree of hypotonia as in infancy and young childhood, some pretty significant. Low muscle tone could result in delayed acquisition of motor milestones, balance and coordination issues. More than half of patients were delayed in walking. But then again, that hypotonia improves with age, but some issues, more minor issues. They walk, they run, they jump, but issues with poor balance and coordination persist. The treatment is therapies. Again, it's worse in infancy and toddler and gets better. Some get more better than others. And this is the big study again showed a slight trend to this being more common in loss of function variants. So variants that cause the whole KMT2A protein to be kind of discarded or thrown away. This hypotonia tends to be a more common feature, but this needs to be studied in even larger studies. Next. Brain MRI findings, again, these are present in about half, but the bottom line about this is these are mild, okay? So you get these MRI reports and you see them and you see the radiologist comment on all of these things. And as a parent, it looks very scary and what is going on and something's wrong with the brain. And as a neurologist, I say, this is not interesting to me, as in this is something that, yes, it's associated with Wiedemann-Steiner, but the brain MRI findings is not what's causing the issues that the child have. It's just kind of another sequelae, but it's the Wiedemann-Steiner syndrome. It's the change in KMT2A that's actually causing the underlying issues in the brain. Next. Now, this one, though, is more significant as far as things that can be found on an actual imaging scan, which is lumbosacral spine anomalies or issues with the spine. It's mostly described in the lower portion of the spine in kids with Wiedemann-Steiner, and that's certainly more common, although we have now seen that there are a number of issues that can extend all the way up even to the cervical spine in our kiddos. In the most severe cases, the spinal column can be incompletely closed and damage can occur to the cord. This is relatively rare. The more frequent finding is a tethered cord, where the cord is inappropriately stuck to the tissue. It can't move freely, and that can cause kind of pulling or shearing on the spinal nerves as the child grows, which can cause problems with that area. Potty training problems in Wiedemann-Steiner are really, really common. Most of you probably know that. And lots of physicians will say, we got to look for a tethered cord. Sometimes they find it because tethered cords are present in Wiedemann-Steiner. Unfortunately, rarely does releasing the tethered cord actually fix the potty training problems, right? The potty training problems are kind of another issue that's there that doesn't necessarily resolve even if you fix a tethered cord that you might see. So it's kind of a separate issue, although once in a while you may get some improvement after releasing it, but that's not super common. Next. Seizures, they occur based on the published literature, occur in about 20% of people with Wiedemann-Steiner, possibly more common in those with a missense variant, so a not total loss of function. And we know very little about this. This needs more study, but the bottom line here is that while seizures can definitely occur, are definitely more common than in the general population, they are actually still the minority of kids with Wiedemann-Steiner actually have problems with seizures. Next. Cognitive. So in earlier studies prior to 2022, this was quoted at 30 to 60% of patients with Wiedemann-Steiner. This is likely due to underreporting of these issues in published cases, meaning the geneticists who described the reports of people with Wiedemann-Steiner described their facial features, their spine abnormalities, their feeding issues, but they didn't really comment on what their cognitive was, or if they did, it was vague and non-specific. In the 2021 study, 97% of the 104 patients had some form of intellectual disability or global developmental delay if they were too young to be called intellectual disability. So clearly this is a much bigger problem than earlier studies reported. Most were described as mild, although a few scattered lower to profound. It's also important to remember that just because there's a 6% who didn't meet the intellectual disability or didn't get classified as global developmental delay. We have not yet met the person with Wiedemann-Steiner. Perhaps they're out there, but we have not met the person with Wiedemann-Steiner with 0 neurodevelopmental issues. Some are more mild, some may be a little bit of learning disabilities, a little bit of ADHD, but a little bit of anxiety, but we haven't met the person with absolutely no concerns in that arena. So definitely we know that KMT2A is very important for the brain, and that if you have something wrong with one of your KMT2A proteins, that your brain probably isn't functioning totally typically. And then a very small study in 2019 suggested that patients had a high prevalence of autistic features. And Dr. Eng has done a lot more work than that study, and we'll talk more about that next. This is just what it generally means when I talk about different severities of intellectual disability as far as general functioning level as an adult. Again, this varies widely and varies person to person and varies with how well that child or adult is accommodated, but this is a general overview. Next. So behavioral issues. Again, these prior studies that were very nonspecific suggested that behavioral issues were present in 40 to 70% of patients with Wiedemann-Steiner syndrome. However, this is again not something that's typically asked about by certain types of clinicians who often publish these case reports. And we think that this is much, much, much higher than that. And honestly, when we see you all in clinic, it's frequently the biggest issue that you would fix if you could, would be the difficulties with behavior. Anxiety and ADHD together with the cognitive issues is the rule, not the exception in Wiedemann-Steiner. So it's not that there's one or the other. They all flow together and complicate each other. And in our experience, patients with Wiedemann-Steiner perform worse at school and have lower adaptive functioning than their cognitive level would suggest due to behavior. So Dr. Eng is going to explain this a little bit more, but basically what we're saying is you test the child in this isolated environment and their cognition actually comes out pretty well. They're able to do these things, right? But when it comes time to perform in school or at their job or whatever, they're not performing as well as their cognition would expect. And that has to do with these behaviors and these other things that may or may not be identified. Next. Sleep issues. We already know that more than 75% of those with Wiedemann-Steiner have diagnosable obstructive sleep apnea that often requires a tonsillectomy and adenoidectomy. But many of these kids still have sleep issues even after OSA is resolved. That was suggested in the 2021 study. And there's a lot more to sleep than sleep apnea. And Dr. Eng is going to discuss that a little bit more as well. Next. Anxiety. So we see every type of anxiety, from generalized anxiety to specific phobias in Wiedemann-Steiner, and it is frequently severe. It can manifest more early, more subtly, like perseveration or adherence to routines, and later become more and more severe where it's actually interfering with daily functioning. Environmental issues can worsen it, of course, if the child's not in the right classroom setting, et cetera. Structure is helpful, and it should be treated in a multifaceted way. So therapy, educational plans, medication all might play a role in your specific child's treatment plan. Another thing Dr. Eng is going to touch on a little bit more next. ADHD and executive dysfunction is nearly as common as anxiety is in Wiedemann-Steiner, and often the more apparent feature in the youngest kids. Anxiety and ADHD could play off each other, they can worsen each other, and they could even complicate, medication regimens for these conditions. It's the ADHD and executive dysfunction. So I purposely do not write only ADHD up there because it's about more than that. It's not only about hyperactivity hyperactivity and poor focus. It's about impulsivity, poor organizational skills, emotional lability, a lot of these things that are dealt with that's more than just what attention deficit hyperactivity disorder would suggest. There's more to it than that. Next. So what might the neurodevelopmental profile look like in Wiedemann-Steiner syndrome? Well, based on, we have more information than what was previously published in the literature now, thanks to Dr. Eng's work, which she's going to talk about now. But what we suspect it looks like is that most kids with Wiedemann-Steiner syndrome fall into the mild intellectual disability range. Some scatter a bit lower than that, some scatter a bit higher. A language disability can certainly be present, but is it probably one of the core features? But visuospatial problems are. Dr. Eng's going to talk more about that. And then ADHD and executive dysfunction, anxiety, yes. Autistic features, I put plus minus, and I put plus minus because there's a very specific profile of autistic features that we see over and over and over again in our research. And Dr. Eng is going to touch a little bit on that. So you're going to hear more about that. Seizures plus minus, again, more common than in the general population, definitely something to look out for. Definitely not the majority of kids with Wiedemann-Steiner. And hypotonia, yes, that improves later, but never goes away completely. Next. So why is this important? It's important for two big bucket reasons. One is for the clinical care of people with Wiedemann-Steiner syndrome, and second is for scientific knowledge and future research. So in the clinical care of patients, we want to be able to provide you all with some anticipatory guidance and personalized medicine, right? So we want to be able to say, you have Wiedemann-Steiner syndrome, and we of course treat every patient like an individual, but we know from other kids with Wiedemann-Steiner syndrome that these are the things that have worked really well, and these are the things that have worked less well. So we're going to at least go first for the things that we know have worked well. And then scientific knowledge and research. So you heard from Tina earlier about lots of work going on in labs we collaborate with, and they're really working on developing potential treatments and targeting treatment windows for Wiedemann-Steiner syndrome. But those actually don't do any good in isolation if we are not ready to actually then bring those treatments to a clinical trial in Wiedemann-Steiner. So we need to know, in addition to having an intervention, we need to know what we're going to test to see if it gets better. And so those are called outcome measures. And those are a lot of what Dr. Eng and I work completely focus on, is developing these and understanding these, and then also developing these clinical trials by understanding more about the underlying brain function and development in Wiedemann-Steiner syndrome. Next. And then clinical care, we've discussed, there are lots of aspects to it. It's not just about medicine, it's about IEP recommendations, it's about looking for comorbidity, therapy recommendations, transition planning, prognosis, getting you hooked up with the right people, etc. Next. So again, for research, a well-designed clinical trial has a specific patient population. Yay, we've checked that box. Here you all are, okay? A therapy or intervention being tested. Well, you heard a presentation on that earlier, okay? So we're working on that. Knowledgeable and collaborative teams. A lot of the speakers you hear from this weekend actually already all work together, collaborate with each other, present together. And so that's very positive. But then we need these appropriate outcome measures. We need to be able to test. So that's where our research comes in specifically. Next. And what makes a good outcome measure? So a good outcome measure has to be reliable. And so we might, if we do some testing on your child, we might ask them to come back again and do the same thing, even though we've already done that. And the reason is because we want to make sure that if we are using something as an outcome measure, that it's staying the same over time without an intervention. And that way we know that if we give your child an intervention and that measure changes, it's because of the intervention. It's not just because of variability. We need it to be valid, so we need it to make sense, right? So if we want to treat cognition and behavior in Wiedemann-Steiner syndrome, I can say, okay, we're going to measure how many ankle sprains your child gets across the course of the trial. That's measurable, it's reliable, it's valid, I could do all that, but it doesn't make any sense, right? It does, like, who cares? Who cares how many ankle sprains your child gets? We're supposed to be treating cognition and behavior. So variation, and that basically has to do with, we have to get the right measures. If all the children are scoring way too low on the measures or way too high, that's not a good measure. There's not enough variability there. And the clinical relevance has to do with what I just talked about. Next. So what are we doing? We are defining the neurodevelopmental issues that we'd want to target in a trial and designing outcome measures. We're validating those outcome measures. We're looking for biomarkers. So some of you all are participating in a study with us that I didn't have time to talk about, and Dr. Eng doesn't have time to talk about, but looking at an EEG measure to go along with the cognition. So those are things like a potential biomarker, something that is quantitative and measurable that we could do along with the cognition to see if treatment is making everybody better. And then we also consider same therapy, different outcome measures approach. So there's power in numbers. Wiedemann-Steiner is a rare disease. Our group and some of our collaborators looked at a number of other related rare diseases. So Wiedemann-Steiner's cousins, if you will. And because of the mechanisms, the genetic mechanisms, it's possible that one treatment could work for multiple of these rare syndromes, but the syndromes may look different as far as their outcome measures. So we think of creative trial designs where we can use the same treatment, but different outcome measures specific to the syndrome, so that we can go to a pharmaceutical company and say, okay, we don't have 1 in 50,000 anymore. Now we have, all of these groups combined, we have 1 in, 7,000. Isn't that a lot more interesting to you? And it should be. Next. All right, so now I'm going to turn it over to Dr. Eng.
All right, and so I'm just going to be talking a little bit about kind of how neuropsychological evaluations take a part in this role that Dr. Harris had talked about, in terms of both for clinical purposes, but also in terms of thinking about more research kind of aims and how we guide research. I think I just want to put this. There you go. So what is a neuropsychological evaluation? So you might have been involved in many different types of evaluations, including speech, occupational therapy, or psychological evaluations. And neuropsychological evaluations incorporate some of those as well. So they'll look at things like language, overall cognition, learning, memory, etc. But really what kind of distinguishes neuropsychological evaluations that this type of evaluations is looking at kind of the brain and behavior relationship. The specific purpose of a clinical neuropsychological evaluation is really, it's a specialized field to really understand how the brain and behaviors coincide in terms of development. Okay, and their cognitive functioning may kind of inform us in terms of the neural networks, the brain networks that are being involved. Again, while neuropsychological evaluation may use different measures that all the other types of evaluations like speech, occupational, or psychological evaluations may use, it's really how we make inferences on the brain that distinguishes this type of assessment. Sometimes we can also detect changes in the brain before necessarily noticing a more global effect in imaging or kind of like imaging study. And it allows you to have a kind of nomothetic or ideographic approach, meaning that allows you to look at that person in a group level compared to other people with a similar kind of backgrounds or similar kind of medical condition, and also individually. So allows you to kind of look at your own trajectory, almost like when you think about a growth curve for height and weight, but for your brain functioning. It can also be used to kind of think about how we can personalize treatments, personalize dosage for interventions, medications, and also thinking about academic programming. So what are the specific type of services that might be more uniquely helpful for your child alone? And then more importantly as well is also thinking outside of the clinical realm, is that how can it be used to think about guiding research questions? It allows us to kind of think about what are more focused areas that we might want to more hone in on in subsequent research studies that would potentially might be a good outcome markers for clinical studies. Okay. For many of you who've been involved in terms of neuropsychological evaluation, you notice that there's multiple domains assessed. It's usually quite a little long testing, but it'll look at things including intellectual functioning, language, visual processing skills, motor skills, attention, executive functioning, learning, memory, and importantly, kind of thinking more also around emotion functioning and adaptive functioning. So adaptive functioning is kind of looking about kind of your life skills, day-to-day skills, how you're able to apply these in day-to-day life. And as Dr. Harrison mentioned, cognitive testing is one component of thinking about outcome markers for clinical trials. When we think about clinical trials, the really first component is really thinking about what are the potential good measurements of change. And so it might incorporate things like natural history studies, like again, asking you questions about diagnoses your child's been given, medical conditions that might coincide with Wiedemann-Steiner syndrome that you guys have noticed. And then the other aspects is kind of having more kind of caregiver questionnaires of thinking about your day-to-day, what you observe in a naturalistic setting for your child, and cognitive testing. So having objective markers of how your child is doing in relation to that. And all those together are what's helpful, right? When we think about just using retrospective or kind of medical chart records, those aren't necessarily as helpful because it gives us a good general idea of how your child is doing, but doesn't really hone in on the specific strengths and weaknesses for a child that allows us to kind of then focus on the areas thinking about the neural functions or the brain areas that might be impacted. Okay. All right, so then I'm going to talk about a little bit about our study that many of you guys participated in for the kind of remote survey study that you guys might have participated in. Okay, and basically how the neuropsychological evaluations that we've done clinically might have guided some of these questions. So not going to talk to you too much about what WSS is, you all know, but like it's a mutation in KMT2A gene, and it's associated again with high rates of risk for intellectual disability and developmental delays. It has the mutation is associated with the KMT2A, which has a similar function as a KMT2D, which actually Dr. Harris does quite a lot of research in with Kabuki syndrome when we think about more cousin kind of MDEMs or genetic conditions. And actually, Dr. Harris had done quite a bit of research in terms of more of the outcome markers for Kabuki syndrome. And one of those kind of profiles that we see, or cognitive profiles associated with Kabuki syndrome, is this kind of unique relative weakness in more visual construction, kind of more visual perceptual processing, thinking about it's associated with the hippocampal function. So it's that specific part of the brain. And this is particularly important because also, Dr. Harris and Dr. Bjornson, who you'll hear about too, is they've done quite a work in kind of leading more of the clinical trial development for Kabuki syndrome. And so if we are able to kind of see if a similar profile in Wiedemann-Steiner syndrome is similar to Kabuki syndrome, we can start to think about, well, maybe some of those trials that would be effective for Kabuki syndrome may also potentially have similar roles in what we think for treatment effects for Wiedemann-Steiner syndrome as well. Okay, so one of the studies actually we just recently published is actually a clinical case series. We looked at clinical neuropsychological evaluations of about 10 individuals who's been diagnosed and confirmed to have Wiedemann-Steiner syndrome. We've reviewed their genetic test records to make sure of that. And about half of these had truncating or kind of more significant loss of variance, and the other half have missense or splice sites, which are less so. And generally, what's the key areas that we're noticing uniquely is first, if you look at the green bars, the green bars are basically children who had tested out of those 10 kind of broadly within normal limits or above. So like generally what we expect for their age. And really the other key aspect to note is the red bars. The red bars is where they're really struggling. So they're significantly below what we would expect for their age at that point. And what you kind of see consistently is that generally for the verbal measures, so verbal reasoning, language, verbal memory, they're doing much better, relatively speaking, compared to the visual component. So got more visual memory, visual spatial processing, visual construction. And again, when we think about what we know from the cousin diagnosis or cousin kind of MDEM, Kabuki syndrome, it's really interesting because it tells us that potentially there's this kind of shared kind of more visual spatial, visual constructive kind of deficits there, which may kind of signal that potentially similar areas of the brain are being impacted despite as a kind of downstream effect from these kind of similar genes being impacted or mutated. Okay, so the second area that I want to highlight, did I press something wrong here? There we go. Oops, there a way I could fix that, sorry. there you go. There you go. So the next kind of point that we kind of really notice a trend is this kind of very elevated attention difficulties and working memory difficulties. So kind of more executive functions. And these two areas are often key areas impacted in what we think of more attention deficit disorder or ADHD. So again, we're going to kind of circle back to that. And third is that actually quite a lot of children with Wiedemann-Steiner had shown actually a relative strength in more sight word reading, but more almost consistently significant challenges in math skills. So math computation, comprehension of math, learning math is seeming to be much more challenging for these individuals testing. Okay. So one of the questions that we had, questionnaires that we had families fill out then is the strength and difficulties questionnaire, which is kind of like a screener on thinking about more behavioral functioning, thinking about hyperactivity, difficulties with like, with kind of more contact, meaning like kind of more like aggressive behaviors, and then kind of more affective symptoms, thinking about like anxiety, mood concerns. And then also more social functioning. One of the key things that we notice is that relatively speaking, so across all the scales, so hyperactivity, conduct, affective concerns or emotional concerns, all those, the higher the numbers, the higher the score is more difficulties, with the exception of pro-social behaviors. That's actually opposite. So the higher the score, you're actually more kind of less concerns are. So you're more pro-social, not more challenges in pro-social behaviors. Okay. And what we notice one off the bat is first, hyperactivity is one area that's significantly impacted in these children. So generally on average, children are scoring very high in clinically significant range there. You can also see that in the bottom graph. In the bottom graph, when you think about kind of more the darker colors represent those who are kind of scoring more clinically significant out of the proportion of participants that responded. And again, you see this very elevated hyperactivity kind of reports across for children, okay? The other area that we'll probably talk about is kind of the social piece, and you'll see the opposite pattern is that the white bars, which is kind of more of like thinking about more within normal limits or more what we think of less concerns, is that the pro-social behavior. So children are scoring very high in social problems, but also kind of in contrast, very high in pro-social or more socially motivated behaviors. And generally, we see this actually when we look at different types of like, when we look at individuals with the kind of more truncated or non-truncated, so thinking about more versus less loss of function, it seems to, doesn't really matter. This seems like very similar patterns across the different variants. So what might contribute to these behaviors then? So what might be contributing to potentially these kind of behavioral difficulties? One of the other areas that we had you guys fill out is the kind of executive functioning, it's a brief kind of inventory on executive functioning skills. And executive functioning includes things like impulse control, cognitive flexibility, problem solving, planning, organization, these kind of very goal-oriented behaviors. And I always talk about executive functions as almost like the cognitive functions that carries out your skill sets. So someone might, for example, might have good academic skills, but if you have really poor executive functioning, you may not be able to demonstrate those skills in day-to-day life just because you're not able to plan, organize yourself, like show appropriate impulse control to be able to actually show your skill sets effectively. Okay. And generally what we see is that those with Wiedemann-Steiner syndrome, like the parents who responded, report generally less actually concerns with more cognitive related executive functions like planning, organization, but actually much more difficulties with executive functions associated with behavior regulation. So things like more about cognitive flexibility, self-monitoring skills, impulse control, those are areas that are more significantly impacted, generally speaking. Okay. When we look at those together then, so we looked at this in relation, thinking about, are these executive functions associated then with these kind of behaviors that you've reported, like hyperactivity, emotional kind of problems? We see that generally speaking, executive functions does not seem associated with affective concerns or kind of emotional problems, but much more associated with hyperactivity and conduct problems. So like things like aggression, maybe like kind of like testing limits, those types of behaviors are more associated with kind of difficulties with executive functions itself, okay? And this is particularly important because executive functions are generally kind of the functions that are the frontal part of your brain. So prefrontal networks are kind of dictates or is more dedicated to. So to give us a little clues to then potentially that's the part of the brain that potentially might be also being affected as a downstream effect of this kind of genetic mutation. And then again, the last kind of third kind of pattern we saw was this kind of difference in discrepancy with kind of significant challenges in math and more relatively kind of preservations in more sight word reading. And this is again interesting because math skills are oftentimes associated with spatial perception and spatial skills itself too. So thinking about learning number line is oftentimes is associated with kind of spatial perception or spatial processing. And so again, this kind of gives us a potential clues then it might be related to kind of those visual spatial kind of deficits as well. We have you guys fill out a kind of questionnaire thinking about where you rated from 1 to 5, being 1 being less concerns and 5 being more significant concerns across reading, math skills, and also more on spatial skills. So reading skills being like sight word reading, reading comprehension, math skills like math facts learning, understanding computation or arithmetic, and then spatial skills being like drawing, organization of materials, lining up numbers. And generally what we see is that your reading is just kind of more variable across the board, but what we see consistently is most families are reporting significant challenges in math, significant challenges in spatial skills as well. So again, what you guys are reporting on day to day, what you are observing is also what we are seeing in the more of those kind of clinical evaluations from some of the patients that we see as well in cognitive testing. Okay. And so then again, when we looked at the different types of variants or different types of mutations, it does not seem to matter whether it's the kind of the truncating versus non-truncating, truncating meaning that higher loss versus less loss of variance, loss of function, sorry. It seems it just this trend of more math difficulties is across the board. So it's just a general pattern we're seeing in Wiedemann-Steiner syndrome itself. Right. So then I'm going to kind of circle back then about this kind of unusual social behaviors, because we get lots of questions about parents then sometimes reporting about like, well, my child has has this kind of unique social presentation. They might have some behaviors like anxieties that seem associated with autistic features, but then also seems to have this kind of counter of like just very engaged, very interested, and very wanting to kind of interact with people. Right. So we want to look at that more specifically. And so we've had you guys fill out questionnaires about kind of these kind of social behaviors, social functions that are typically associated with what we think screen for in children with autism spectrum disorder. So things including social communication skills, cognition, social motivation being like this drive for interaction and interest in interaction, and then more of these kind of restricted behaviors. So kind of the repetitive behaviors, kind of almost like sticky thinking, like kind of get focused on one kind of approach or kind of thought. And generally what we see is that overall, you guys are families who responded are really reporting very high rates of particularly more repetitive and restricted interests, or really kind of more of the sticky thinking, kind of repetitive behaviors. And often that is coinciding with anxiety itself. And then actually what we also see is this kind of unique, this unique kind of elevation in almost kind of more preservation in social motivation, meaning that there's not really that what we see, this kind of unique pattern of where we don't really see in children with autism is that children with autism might not be necessarily as engaged, whereas socially engaged or have the social drive, whereas children with Wiedemann-Steiner syndrome almost generally seem to be much more interested in interacting with other people, despite not maybe having the technical skills to know how to do it as appropriately, okay? And so then there's a question, well, is this specific to Wiedemann-Steiner syndrome, right? How can we know if this is just with Wiedemann-Steiner versus maybe it's other MDEMs or other genetic conditions or other individuals who have maybe similar kind of cognitive functional levels? And so we have compared this with another kind of MDEM or another kind of Mendelian disorder that we also do research in with Cat6A syndrome. And generally, actually, Cat6A syndrome have higher rates or a more significant intellectual disability than what we typically necessarily see in range with Wiedemann-Steiner syndrome. And interestingly, what we see is that actually, what Dr. Harris has mentioned, the behavioral difficulties seems to be independent of that, right? So like what we see is that even though Cat6A syndrome is associated with typically a little bit higher level or more severe intellectual disability than necessarily those with Wiedemann-Steiner syndrome, those with Wiedemann-Steiner syndrome are much more elevated in behavioral difficulties than those with Cat6A. So it tells us that it's not necessarily potentially just the cognitive level that might be driving necessarily, and there might be still specifically uniquely there more some behavioral challenges with Wiedemann-Steiner syndrome that we might want to look for. Okay. Then we also looked at here. So again, here just kind of representing again more of these kind of emotional kind of conduct difficulties, much more elevated in Wiedemann-Steiner, which is on the top graph, and a bottom graph of Cat6A syndrome. Again, if you look at the dark bars, that's where you're scoring kind of more clinically significant range, and those with Wiedemann-Steiner is kind of Steiner syndrome is scoring generally more elevated than those for Cat6A syndrome, which are more kind of like less concerns in that realm. Okay. Both the syndromes though seems to be have shared kind of higher rates of hyperactivity. But what's also interesting uniquely to Wiedemann-Steiner syndrome is that, again, this high social pro-social drive, whereas those with Cat6A syndrome don't necessarily show that. Okay, so again, that tells us this kind of social like phenotype versus social profile, it seems to be very specific to the syndrome. And again, when we looked at this kind of questionnaire across both syndromes, looking at more autistic features, even though some show some similar trends, only really relative in those with Wiedemann-Steiner syndrome, they're only within this group, we're seeing this kind of discrepancy of where their social motivation is uniquely less affected than all other areas. Whereas the Cat6A syndrome, which is much more smaller group, don't necessarily show that. So again, shows us that these patterns, what we're seeing seems to be very specific to this condition. Okay, so lots of things we kind of display to you. What are next steps then, right? So these are really just first steps to kind of give us clues. These questionnaires are really just to help us start to hone down on studies that we're going to talk about, okay? And so what it does tells us is that, again, there potentially might be the hippocampal areas where responsible for some of the visual kind of construction kind of functions might be impacted. And similarly, the prefrontal networks, kind of the areas for executive functions might be impacted. However, we need to actually do much more kind of cognitive studies to really mark those, right? Because these are based on behavior observations from you guys, but we need more cognitive objective testing measurements to kind of support that, okay? We also want to do more research when you're using multiple kind of methods, right? So thinking about imaging studies to make sure that the kind of neurobiological kind of measurements also coincide with what we're seeing in the cognitive measurements, okay? Similar patterns of these areas being affected. And we'll need to have more variety in testing. So when we do testing, oftentimes in neuropsychological testing, we do a few measurements to kind of get a general sense of a function. But once we can hone down on one area that's being affected, we need to do much more different tests that we know have been demonstrated to assess that area of the brain to really kind of see, are these all consistently hanging? These patterns of results are consistently showing this kind of pattern of challenge, okay? Then the other areas that, we also want to look at more is this kind of social pattern, the social cognitive pattern of this higher kind of almost this high social drive, high hyper approachability paired with more social communication, cognition, and kind of repetitive behaviors, which are, again, typically is also associated with anxiety as well. And then, but importantly, one of the areas that we really need to do is also these kind of cross-endem or cross-genetic condition research, because if we're able to do that, we can then start to hone down on what are overlapping features and what are more unique to each syndrome. And these can also tell us then what are potentially different syndromes where, when we know clinical trials have been starting to kind of make more gains, that we can start to think about might be adapted for Wiedemann-Steiner syndrome itself too. The other kind of genetic conditions that we want to think about too, who share its very unique kind of hypersocial drive is actually a Williams syndrome, which is a different type of deletion. It's a deletion in the 7q region. And so, but they show this kind of unique kind of nonverbal kind of challenges or nonverbal reasoning challenges, but paired with this very specific pattern of high sociability paired with also very technical challenges in actually the social interactive skills. And then last is that we want to make sure that we want to look at this in relation to kind of, again, kind of control groups who don't have necessarily the genetic conditions, but might have these cognitive challenges. And all these combined would then help us to tease apart what are more specific challenges or kind of downstream effect from this kind of genetic mutation, okay? And so then I'm gonna do a little shout out for our cognitive study, right? So all those what we talked about today is just kind of little clues that we've gotten on studies that you participated in to tell us what are next steps, what are things that we really need to focus our efforts in. And so we're doing several studies. We're kind of splitting. Some of you might be seeing Dr. Harris and some of her clinical coordinator, who's also working with EEG studies over at Kenny Krieger's institute right now. And then we'll be also doing cognitive studies. Some at this conference. We're also doing it at our clinic outside of conference for families who might not be able to schedule in these couple of days. But your participation in these is what's going to be helpful for us to kind of really get more objective data to make sure to really get a sense of, are these patterns really holding up? And so, like, again, if I'm going to give a little shout out that if you have any interest in time that you welcome to kind of talk to us, and we're more than happy to talk about what these studies would entail and figure out a time that will work for all of us. Okay. And we just want to give a few acknowledgement again for the foundation for supporting our research studies, or IDDRC, which is kind of like our research kind of core over at our Kenny Krieger Institutes for providing us support for the research studies as well. And Dr. Farner, who wasn't able to make it, but Dr. Bornson, who you'll probably see tomorrow at giving his talk, who was also going to be kind of giving his talk on his research projects on WSS as well. All right. And any questions for us? I know kind of lots of things.
Hi, I'm Sarah Spear. I'm a parent of a child with WSS, and you've consistently said autistic features. So I'm kind of curious about your perspective on syndromic ASDs and if your research has gone down that path at all.
So yeah, right. So you probably have lots of families have this discussion, is that there is a kind of a little different presentation with syndromic kind of like autism, right? But and then the idiopathic, but so autism is technically more of kind of like behavioral diagnoses in a sense that actually is based on what we think of core kind of social communication kind of deficits, and then also kind of difficulties with kind of more restricted interests, repetitive behaviors, and sensory processing issues, right? What we typically see for some syndromes, but not all syndromes, is that we see some of these syndromes might have some of these more social challenges because of the communication styles, because of kind of the cognitive pieces, but also a large part because of the anxieties too. The anxieties in interacting with other people in kind of the less structured settings and kind of unpredictability or transitions, but don't necessarily have the kind of less interest in social interactions that we typically see in some individuals with autism necessarily. Why it's important though to kind of differentiate these two is because when we think about school placements, we think about the types of interventions, behavioral interventions as are more appropriate. We want to think of it more specific to your child, right? So what might be helpful for an idiopathic or individual autism without genetic conditions might not be necessarily appropriate for those with Wiedemann-Steiner syndrome or those with syndromic autism, in a sense that, for example, if your child is very, very social and likes that engagement, you might want to kind of preserve that. You want to preserve that might be something that keeps them interested in school, right? And if you put them in classrooms or in different settings where other children might not necessarily display that, it might not necessarily be a good fit. And so I think part of our research really is to kind of differentiate those. And so that when we think about personalized treatments, it's specifically looking at these patterns so we can think about what down the road, when we see individuals with Wiedemann-Steiner, are kind of more specific kind of approaches that we want to take to with those with affected syndrome.
And the other piece of that is that anxiety features and autistic features can overlap. Okay. And when it comes to, again, treatment means a lot of different things, not only medicine, okay? But when it comes to pharmacologic treatment, okay, anxiety is treatable, autism is not, right? So we don't want to miss the treatable thing that could significantly affect the quality of life for your child. So we want to make sure that we differentiate that for that reason as well. And then scientifically speaking, when we're thinking about regions of the brain, testing to develop outcome measures, all those things like that, it makes a difference. But certainly tons of kids with Wiedemann-Steiner have an autism diagnosis from school and things like that. And it's not inappropriate. It's just more nuanced, like Dr. Ang was talking about.
Hi, my daughter also has probably the 20% that has seizures. And so she has Lennox-Gastaut and also ESES, which was diagnosed in the spring, which has been really impacting to us since we thought we had it down. We're okay, we have WSS, we're good, we can figure this out. And then that came in, that diagnosis, and I feel like it's regressed. And she's being seen at Stanford Children's Hospital because we live in California. And after the second treatment of Valium, it didn't actually control the ESES. And so we're gonna kind of go back. And I'm just wondering if you've done any research around which the 20% that does exhibit seizures, and is there any treatment that you've seen that has been supportive to these particular children?
So really, really good question. So the answer is that research really needs to be done because we need to know if there are specific seizure treatments that work better or worse. And certainly ESES is very commonly associated with regression and problematic. So we need to learn tons more about that 20% who do have seizures and what those seizures look like and how to treatment. We don't have any data on this. Anecdotally, I will tell you that in my practice, a medicine I use commonly is a medicine called Depakote. Even though it's associated with a lot of side effects, it's an older medicine. And the reason for that is because molecularly, thinking about KMT2A, there may be some actions of Depakote that work nicely with what's gone wrong in KMT2A, but that's really anecdotal. And so there needs to be a lot more research on it. It's a great question.
Is it on? Yeah. Okay, so we previously saw how they're on a growth chart. They're just significantly below, but they follow the same growth chart. And you just said about the neurodevelopment. Is that something, are they following kind of the same? So as they get older, I mean, my son's 18. So is he at 19? Is he going to be like, because I would say he's probably 10 or 11 cognitively. Would you see that that's growing, is that going to stay stagnant? Yeah, where's the plateau? Like, are we going to be 11 forever?
Yeah. So that's why we do more kind of these repeat assessments because that varies for each child, right? So when we think about growth charts, right, what you're describing, we think about there's that general kind of height, weight sometimes when we see pediatricians or anything, right? But then we think about cognition is very similar. It's just that your child might be going in a different curve, and it's kind of like looking at figuring out best way for us to kind of figure out, well, how does that curve look like, is to do that repeat testing, because once we start doing repeat testing, we can kind of get a sense from each kind of interval, what does that change look like? Is it stable? Are they making any changes? Are they making improvement? Are they kind of starting to show kind of stagnation a little bit earlier? And then kind of thinking about also about are they having optimal kind of treatments in between during it, as we're kind of looking at those intervals as well, and what we can do to kind of change that. Generally speaking, it varies. When we think about plateau, there are certain, we sometimes see, for example, individuals with more mild intellectual disability might have plateau for certain academic skills around third, fourth grade level. But again, when we think about plateau, it varies across different functions, and what complicates things is that when we think about different cognitive functions, they develop at a different rate too. And so that's why we do so much different testing. Sometimes families are like, well, why does it take all day to do testing? And we do all these different testing because when we think about, for example, executive functions, they continue to develop all the way to adulthood, where some of the visual spatial skills, you start to see some kind of plateau at a much earlier age because we don't necessarily make as much of those gains at typically developing as we would as for executive functions. That's just how the brain's kind of wired developmentally speaking. And so, that's where that kind of repeat testing is helpful, because we're starting to almost make these kind of unique charts for different areas of those or different cognitive functions to think. And when we think about plateau, is that if are certain areas being plateaued and then others are still growing, are all consistently doing that. And then sometimes other coinciding conditions like seizures and stuff might impact those kind of areas, these kind of charts as well. And so I think that it's challenging to necessarily say what is that one number, because we can't necessarily provide that. It's really unique to each child that we're going to have to kind of test to be able to help you kind of get a sense then what we're kind of prognostically thinking.
So all of you who have seen us clinically know that Dr. Engel gives the much more eloquent and appropriate answer, and I'm a little bit more the blunt one. And so honestly speaking, your child will continue to gain skills, to learn new things, to develop new skills, but cognitively, probably you're at 11 and 12, okay, forever, barring disease modifying treatment, which we hope will be coming down the road.
Thank you for this. Thank you for these studies, which is most encouraging. I have a few observations on my son, which I want to ask some questions about. Okay. One is you talked about hypothermia and the low muscle tone. But we've noticed recently, he's getting so strong that when he stiffs his leg or his hand, it takes just about all my strength to pull him out or to straighten it. Is this related to the syndrome? Okay, this is one question. Should I continue or allow you to answer that before I go to the next one?
I can answer that quickly. So yes, it is. So it's related to his low muscle tone. And so, as we've discussed, low muscle tone is just the way that his muscles are in sort of their resting state, right? It's the way the brain controls the muscles and how tight they are. It has to do with posture and things like that. But, Chim and all the other kids are really strong, right? And the Wiedemann-Steiner does not affect muscle strength. So the muscle strength stays there, but the hypotonia, the low tone, also stays there in some form. And so kids with Wiedemann-Steiner often have to use their muscle strength to compensate for their kind of wobbly balance that other people have sort of more naturally and don't have to actively think about and actively activate muscles to carry out.
Okay, and does that also contribute to he's very heavy now, we can't lift him?
Yes.
For his age.
Yes.
Is that part of it also?
Yeah, I mean, he's definitely gaining weight and things like that. But yes, his body, like his body when you lift as compared to, the other kids, right? The other kids, when you lift them up, they sort of engage their tone to kind of grab onto you, make it easier to carry. Whereas kids with low muscle tone will help you and they're strong, but their bodies, as far as carrying them, are a little bit more like a sack of potatoes analogy, where it's very, very heavy and hard to get them off the ground and move them around.
Okay, I think there are some hands over there. Let me ask somebody else.
Okay, we have and they'll be around the rest of the day here, sir, so you can pepper them later. Okay. We'll go Jenna, and then we'll go up to the front.
And I apologize if this is too specific, but I'm not sure if I speak on behalf of other people. Some of us aren't able to ever see someone who's even heard of Wiedemann-Steiner syndrome when we're seeing people for our children. And a lot of times the feedback I get is like, oh, your kid will grow out of it. Like, this is an issue, but your kid grows out of it. But our kids barely grow. So it's a very slow. So my question is do you feel like, maybe this is a personal choice, but should I be pushing more to do the intervention then instead of just assuming they're going to grow out of some of these things?
Yes.
Yeah. Cause specifically, we're having sleep apnea and my doctor's telling me well, we can do adenoidectomy, but usually kids will grow out of it and things will widen, but I'm
not
thinking
kids with Wiedemann-Steiner.
Okay.
Nope.
So yeah. So in general, I can be think in my own head, push for those things because our timeline on growing is so slow.
Yeah.
Okay.
And also we're, I don't, just FYI, we're here, right? Even if you live far away, we're available. If you want to email us and ask questions, if you start your line of the email with "my child has Wiedemann-Steiner," we'll answer you. Okay, so we're here to help you too. Oh.
Yes. Thank you so much for the work that you're doing. I know we've talked about sleep apnea. Has your work revealed other causes for the sleep disorders? Is it the hyperactivity? Is it the anxiety? I've been to a million neurologists. My daughter doesn't sleep.
Yeah. So sleep difficulties we just recently had our publications on, is that we have noticed that the sleep difficulties are associated with the hyperactivity. So like, generally speaking, when we see like that very elevated hyperactivity, one of the things that we then want to know that, like what we mentioned, is that we want to make sure sleep is well controlled, because one of those behavioral challenges are likely possibly coinciding with the kind of like the sleep challenges that you're noticing, especially more sleep behaviors itself. Okay. That being said, like, and you might want to talk a little bit more sleep apnea kind of aspects, but like, a lot of the sleep behaviors too are associated with some of the executive and kind of more of kind of dysregulated behavior too, right? Like, a lot of parents were reporting a lot of sleep behavior concerns, almost beyond some of the breathing challenges. Sleep behavior concerns being like kind of like challenges of going to bed, sleep initiation, and more of the actual going to sleep than the actual like snoring or like breathing challenges that parents might see, but like child may not necessarily notice themselves. But beyond anything, most parents are reporting more of those behavioral challenges, like getting them to go to bed, staying in bed, having regimen like to go to sleep. Those are much more very challenging for a lot of families that we're noticing, and probably would help benefit to see like a behavioral psychologist who can help with behavioral strategies, like sleep hygiene strategies around that.
Hi, I have a question about the anxiety features that are seen in WSS. And specifically things like sticky thinking, sort of like OCD type of thinking. And I'm wondering if you find that medication does help that in particular?
Good question. Yeah, yes, it helps. Most of the families that I treat will tell you it helps. It doesn't eliminate. Okay. It stays. It's still a problem. It deals with it. Any medicine that you start for anxiety or ADHD in Wiedemann Steiner, it really helps to have a good relationship with your provider who is prescribing the medication, because it needs lots of tweaking. And the other thing that I will say, and I talk to lots of families from all over and sometimes I just provide this via email to the provider who gets uncomfortable. But I have found that in Wiedemann Steiner syndrome, specifically for anxiety medicine, that I often need to push the dosage much higher than other providers might be comfortable with doing in children. And then we see the effect that we're looking for. Okay. And I haven't had anybody have certainly people have side effects. We've gone off the medicine for different reasons, but nobody has had catastrophic side effects. It seems like the kids with Wiedemann Steiner can tolerate and need these very high doses in order to get the effect that we're targeting.
Thank you.
All right, we have our last question because we're standing between lunch and it's back here in the corner. Doctors?
Good afternoon, everyone. My name is Stella. My question is on phobia. With regards to phobia and WSS, we know that every human being has a phobia, but how do you differentiate a phobia that is characterized with WSS and a normal phobia, and how do you address that? Do you use techniques like flooding to get rid of it?
Yeah, so we definitely see sometimes specific phobias in Wiedemann Steiner syndrome as part of the anxiety picture, which, as Dr. Eng was saying, is multifaceted. We see lots of different types of anxiety coming in, and phobias are one of them. And when we see them, we do use, when necessary, we use desensitization therapy is what it's called, to often get over those. So kind of repeated exposures combined with some what we call cognitive behavioral techniques to help with that. But again, that's unfortunately another thing that tends to be limited to sort of where you live, what providers you're able to do, because desensitization therapy is something that needs repeated over time, and it's kind of an intensive thing and it takes time. And you really want to do this kind of therapy with a provider who is familiar with kids with developmental disabilities, because it is quite different than just working with an otherwise neurotypical kid who's developed some sort of phobia to spiders or something like that, right? It's a different thing. And so unfortunately, that can be difficult. There are lots of creative ways that people are doing it in the age of, kind of COVID virtual visits and things like that. And so, that may be something to pursue, but that is how we treat it typically, and combined with pharmacological treatment when necessary.
Okay, we want to thank Dr. Ng and Dr. Harris for being with us. And they will be around and they will be doing studies with a few of our kiddos today and tomorrow. If you haven't signed your child up, I believe there might be 2 spots left. So make sure you touch base and we will break for lunch until 1 o'clock.